Hello again. In Chapter 12, we covered coding and reimbursement. In Chapter 13, we talked about compliance. And now the very next step is we're going to talk about some real world data and how it all comes together in Chapter 14. And again, this is a summary of Chapter 14. Please make sure that you read the entire chapter and the complete slides that are posted on Moodle. This video lecture will cover the principles of healthcare reimbursement and give you some data examples in the real world. When we talk about the case mix index, the CMI calculation, this is basically measuring the complexity of the healthcare organization's patient. And we can take that measurement of how complex our patients are at a hospital facility and compare that facility to both national and state benchmarks. This analysis can include trends, growth, decline, changes, and other vital information. The outpatient service mix, or SMI, is basically the equivalent of the CMI, the case management index, case mix index, excuse me, but for outpatient. And this is based on the ambulatory payment classification weights that we took a look at earlier. This helps in outpatient service revenue analysis. Then finally, we have the MSDRGs. The MSDRGs we covered for Medicare Part A. And these are MSDRGs, in other words, groupings of like diseases, and then the MS for Medicare severity within. And these include within each one different things that can change the MSDRG. We really want to avoid over-reporting or upcoding anything or missing things. Earlier, when we talked about MSDRGs, we did that one assignment where we looked at changing the CC or MCC and how that could change the MSDRG. This is where proper documentation is critical for accurate coding and billing. We also have Medicare reimbursement variation analysis, and this is the difference between what we're actually seeing and what's expected. Now, with electronic health records and other technology, we can keep tables on a national, regional, state, and local area to compare apples to apples. And then as a result, we can look at the variation and see what our expected reimbursement is going to be. Usually this requires some sort of collaboration between the financial analyst and the coding professionals. And a lot of times what is done is they'll take a look at this expected MSDRG, and if they find out things are being undercoded, look at how much potential revenue we could bring in. The site of service analysis is basically looking at inpatient versus outpatient. In the quality course, we talked about utilization review, and this is basically managing the patient at the correct level of care. So in other words, if somebody doesn't need to be admitted to the hospital, we're not admitting them. They're meeting some sort of medical severity or other criteria to ensure that they're admitted appropriately. Some MSDRGs are automatically reviewed by Medicare for improper payment. And finally, we get to evaluation management, facility coding. And these are the different levels of services. We want to make sure that we're coding things at the right level of service so we get reimbursed appropriately. And we always put coding on the coders, but reality is physicians also have to follow national E&M coding guidelines. particularly with electronic health record systems that have semi-automated tools to assign codes. Payers do audit physician coding to look at compliance risk, and there are all different types of statistical analyses and bell curved analyses to look at the outliers and coding trends and so on. The outpatient code editor review is basically software that processes claims for OPPS pricing and compliance. Looking at these results helps optimize revenue cycle performance. And again, we talked about RVUs earlier. Now we can take a look at this and map this to physician productivity analysis. So in other words, how efficient is the physician based on time and complexity of services? And this is a good metric that many practices will look at to balance productivity with quality of care. And again, clinical documentation integrity analysis helps ensure that we have accurate clinical documentation. And these metrics track program effectiveness and compliance. And that's all I have for you. Thank you for watching this video lecture. Please make sure that you read chapter 14 and the slides in their entirety to make sure that you are up to date and have a complete understanding of this important material. That's all I have for you. We'll see you online.